In this video, we're going to talk about a lot of the different drugs and the medications that are available for ulcerative colitis. Now, I think it's very important that we understand the actual immune response that takes place in people with ulcerative colitis before we even get to the actual medication. Because a lot of these drugs, they actually work by inhibiting some of these processes to be able to alleviate the symptoms. So let's dig right into it. Now, if we take a look at the actual intestine, we have to pay attention to two different things. Number one is your mucin barrier, which is a green looking barrier. And the job of this barrier is to basically protect your epithelial cells from different types of toxins and the bacteria that are present inside your colon. And you also have these tight little junctions in between your epithelial cells in a normal person. But in people with ulcerative colitis, what happens is this green mucin barrier is compromised. And also, these tight junctions become very loose, making these epithelial cells very, very leaky. So what happens is all this bacteria, or any of this bacteria for that matter, or the toxins from the actual lumen of your intestine starts to move into the tissue of your intestine. And this is where the actual problem begins when it comes to the immune response. Once the bacteria is out in the actual epithelial tissue, it gets in contact with the first line of defense. Now, these are cells called antigen-presenting cells. But specifically, we're going to only talk about the macrophages. There are other ones called dendritic cells, but we're not going to talk about those. So what happens is, as soon as these bacteria get in contact with macrophages, what these macrophages do is they basically break down this bacteria into little pieces. They basically eat the bacteria and break them down into little pieces. And they present these little pieces to other different types of immune cells, or they're part of our adaptive immunity cells, called naive T cells. And when that happens, these cells also get activated. Not only this, your macrophages also release different types of pro-inflammatory cytokines, such as interleukin 6, interleukin 1, and TNF-alpha. Okay? Now, once these naive T cells, they get activated, what they do is basically they proliferate and differentiate into two different types of cells. There are more, but we're only going to talk about two different types of cells. One being cytotoxic T cells. Now, just by the name of it, they're very toxic. Their job is to kill the bacteria. Okay, we'll leave it at that. And the other different type of cells are Th2 cells. Now, these are the most problematic cells that are present in people with ulcerative colitis. Once you have these T cells or Th2 cells, they start to pump up lots of cytokines. One of them, which is very prominent, is TNF-alpha. And the other ones are interleukin 4, interleukin 21, interleukin 6. There are other ones as well, but we're only going to pay attention to these ones. And what happens is these cytokines, they also work on different types of your immune cells called B lymphocytes. And they basically convert these B lymphocytes into other different set of cells called plasma cells. And it's the plasma cells that produce a whole bunch of antibodies against this pathogen or the bacteria. They're very specific antibodies only present in people with ulcerative colitis, not in Crohn's disease, only with ulcerative colitis, called p-ANCA antibodies. We'll leave these cells here for now, and then we're going to pay attention to the actual pro-inflammatory cytokines that we've been talking about. More specifically, TNF-alpha. What it does is basically it goes to the nearby blood vessels and stimulates the actual cells of your blood vessels to make a certain type of protein called selectin. Now, why this selectin protein is so important is because you see how you have all of these different types of white blood cells in your blood vessels called neutrophils and monocytes. They also have a little hook on their surface called integrins. And these selectins basically bind with these integrins and pull these white blood cells into the area. You see how you have neutrophils in the area? Now what happens is these neutrophils, they can also take oxygen and make reactive oxygen species, these free radicals, in order to kill the bacteria. So what do we have so far? We have reactive oxygen species from neutrophils. We have antibodies from plasma cells. We also have cytotoxic T cells. All of them are trying to destroy this bacteria. But unfortunately, they not only destroy the bacteria, they also start to destroy your own cells of your intestine. And you know how your cell membrane is made up of phospholipids? There's this really sneaky enzyme called phospholipase 2. What it does is basically it starts to convert these phospholipids into arachidonic acid. And once you have arachidonic acid, there are two other enzymes called LPO and COX-1 and 2. What they do is they convert this arachidonic acid into leukotrienes and prostaglandins. These are also the pro-inflammatory cytokines, just like the other ones. And both of these also perform the same job of making these blood vessels more permeable and to bring all these white cells like neutrophils and monocytes into the actual intestinal tissue, which propagates the same inflammatory cycle over and over. Now that we understand this whole inflammatory cascade, let's quickly take a look at the different medicines or drugs that are available to be able to inhibit some of these pathways and put somebody in remission or maintain that remission. Now, these drugs are basically divided into three different categories. First one is mild to moderate symptoms, moderate to severe symptoms, and severe symptoms. Under mild to moderate symptoms, we have sulfasalazine and 5-ASA. These drugs basically act as anti-inflammatory agents. What they do is they basically inhibit these two enzymes, LPO and COX-1 and 2. And if you inhibit both of these enzymes, are you going to be able to convert arachidonic acid into leukotrienes or prostaglandins? No. So if you don't have leukotrienes and prostaglandins, are you going to be able to bring these white cells into the area? No. That means you decrease the inflammation. And the second one is locally acting corticosteroid, which is budesonide. This can also be used for initiating the actual remission. Corticosteroids, since it works only inside of the intestine, what it does is basically it would inhibit this PLA enzyme and inhibit this whole process of making new cytokines. It can also shut down the production of interleukin-1, interleukin-6, and TNF-alpha by working on these macrophages and T cells. It can also inhibit the proliferation of these T cells into all these different types of T cells like cytotoxic T cells and Th2 cells. Okay, so these are these drugs work on different pathways within your immune system. Most of the time they work only inside your intestine, specifically the budesonide, but there is a good chance it can also work systemically. And the second category of drugs is moderate to severe symptoms. First of all are corticosteroids. These are only used for inducing remission, not for the maintenance. And we'll talk about why. We'll talk about it why. The first one is prednisone. Again, same mechanism of action that we talked about budesonide. It shuts down multiple different pathways of your immune system. The only problem is these ones, they actually work systemically. So they can work in your entire immune system, which could be problematic anyways, because it will shut down the entire immune system for however long, and which puts you at a higher risk of developing different types of infections in different parts of your body and other diseases as well. And so only for remission, not to maintain the remission. But in order to maintain that remission, there are other different types of drugs that we're going to talk about. First one is methotrexate. Now, you know how you eat folate, and there's this little enzyme that converts folate into tetrahydrofolate? And this tetrahydrofolate is something that we use to make purines and pyrimidines. These are nitrogenous bases that you need to make your nucleotides. Now, nucleotides are basically the building blocks of your DNA. So if this process works normally, you make more DNA, you make more T cells, and you make more inflammatory cytokines, which leads to this whole inflammatory cascade. Now, what if you were to give this patient a drug called methotrexate, which will inhibit this enzyme? Now, if you inhibit this enzyme, are you going to be able to convert folate to tetrahydrofolate and tetrahydrofolate into these nitrogenous bases and nucleotides and DNA? No. So as a result, you shut down this process and you basically inhibit the production of new T cells and these cytokines, reducing the amount of inflammation. And the third drug is Azathioprine or 6-mercaptopurine. The way this drug works is has multiple different pathways. They work on T cells. The first pathway is basically they act as fake nucleotides and they insert themselves into the actual DNA. And what happens when you have a fake nucleotide inside your DNA? Your cell triggers a response to this called apoptosis, which is a programmed cell death, because this DNA is not good for any use, so your cells will try to kill themselves. Okay? As a result, you destroy these T cells and no production of cytokines or any more T cells. Okay? And the other pathway it works by is there's this enzyme, shouldn't say enzyme, there's this protein that works as a signaling agent for your T cells. And it tells your T cells DNA to make more interleukin 6, interleukin 1, TNF alpha, all these pro-inflammatory cytokines. What if you inhibit this enzyme or the protein, signaling protein, with this drug? Are you going to be able to make more cytokines? No. As a result, you reduce the amount of inflammation. Now, let's get into the third category, which is for the severe symptoms. And the first one is anti-TNF alpha agents or infliximab. Now, you know how we've been talking about this very problematic cytokine called TNF alpha, which was basically propagating all this inflammatory cascade nonstop? What if we block this TNF alpha with the drug or the biologics? Is it going to be able to go to these cells and bring more white cells into the area? No. As a result, you decrease the amount of inflammation. And the second drug is anti-integrins or vedolizumab. Now, these drugs are only used in severe cases. You know how we talked about these little hooks in your blood vessels or the cells of your blood vessels that bind with these specific proteins that are present on the surface of your white blood cells called integrins? What if you use a drug to block these integrins or the proteins available on the surface of your white blood cells? Are you going to be able to bind these integrin proteins to the selectins and bring them out to the surface of your intestine? No. As a result, you shut down the migration of these white cells into the area and reduce the amount of inflammation. And the third option is IV steroids or methylprednisolone. Now, your healthcare provider may give you this drug just in case other drugs are not working on you or the PO steroids are not taking effect. At this point, the patient is very, very sick, basically. To induce the remission, they may utilize this drug. Again, corticosteroids have multiple different pathways that they work on. They shut down the production of cytokines, different types of cytokines. They shut down the proliferation of TH cells. They shut down this PLA2 enzyme. And they also shut down the migration of new white cells into the area. Okay? So that's pretty much everything that we need to know about the medicine and the mechanism of the medicine when it comes to ulcerative colitis. And if this video really made sense to you guys, please give us a like and subscribe to our channel so we can continue to make these valuable videos for education purposes in the future. Thank you.